بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Today we will continue our CAPI program, episode 3. As we all know that a CAPI program is a self-experienced episodes of perspectives of coronary intervention, innovative tips and tricks created by me. My name is ELShafey, consultant of intervention cardiology, Manufia University Hospital, and the fellow of the Royal College of Physicians, Glasgow, and fellow of CAPI. Today we will discuss one of the applications that could be implemented based on the ELShafey speculation or the inverted grayscale coronary angiographic pattern. One of these applications is a modification of the Gerald Werner score of coronary collateral connections score, which is used basically during retrograde coronary total occlusion revascularization strategy. The title of our paper today is a coronary collateral connection score in chronic total coronary occlusion lesions in view of ELShafey speculation. Authors, me and Professor Alfredo Rogero Galassi, is a well-known expert and was the Euro CTO Club president. So before we go to talk about this modification of the Gerald Werner score, we will introduce some of the information about the CTO coronary intervention. As we all know that the human coronary collaterals are intercoronary communications that are believed to be present from birth. In the presence of chronic total coronary occlusion, a total occlusion of perceived or known duration of 3 months or longer is labeled as chronic occlusion. Recruitment of flow via these collateral anastomosis to the arterial segment distal to occlusion provides an alternative source of blood flow to the myocardial segment at risk. Although coronary angiography is the standard method to visualize coronary collateral arteries, it has a limited resolution. The visible collaterals have a diameter from 0.3 up to 0.5 mm. Therefore, arterioles lower than 100 micrometer are unseen by the human eyes. Adequacy of collateral circulation can be assessed by various methods. These coronary collateral channels have been used successfully as a retrograde access route for percutaneous revascularization of chronic total occlusion, and the godfather of this technique is the Osamu Kato, the well-known expert, Japanese expert of CTO intervention. The anatomic collateral pathway was first categorized by Levin into 26 different types and summarized into 4 categories: septocollaterals, intra-arterial or bridging collaterals, epicardial collaterals with proximal takeoffs, atrial branches, and epicardial collaterals with distal takeoffs. In case of coexisting collateral pathways, the one that first opacified the occluded epicardial segments was defined as the principal collateral. Now I will present some of the classifications of the coronary collaterals, and I will start by the oldest one, which is the Cohen and Reintrope classification. Reintrope classification is proposed at another classification that divided the collateral connections into 4 groups according to the grade of occluded segment opacification. He classified it into 4 grades. Grade 0 is no filling, grade 1 is side branch filling of the artery to be dilated using collateral channels without epicardial segment visualization. Grade 2 is the partial filling of the epicardial segment using collateral channels. And the grade 3 is the complete filling of the epicardial segments of the artery being dilated using collateral channels. Recently, and this is our scope of talking today, is the Gerald Werner score. Werner proposed an evaluation of the size of coronary collateral connections diameter measured by three grades: CC0, where there is no continuous connection between donor and recipient artery; CC1, continuous thread-like connections; and CC2 is continuous small side branch-like size of the collateral throughout its course. So, as we all know, the ELShafey speculation is based on using a modified pattern of the inverted grayscale of cine angiograms for a better visualization of different ambiguity coronary artery lesions. When applying these assumptions with the help of one of the CTO international experts, as we all know, Professor Alfredo Galassi, for revising cine angiograms of different cases candidate for retrograde revascularization approach, we show it when traditionally marking a case to have a CC grade 0 after meticulous revision by inverted grayscale with modified image contrast, many cases were upgraded to CC1. Here are some of these examples. Here in this figure 1, as we all see, this is an ambulance lift engaging the totally occluded chronic total occlusion of the mid-RCA, and this is the antegrade filling of the LAD with, as we see here, there is some of the septal connections, but with a regular angiography, as we see in picture A, you cannot clearly demonstrate any connections. But when we invert the grayscale mode, as we see here, there is a direct visible connections between the proximal stump and with the septal collateral from the LAD, as we see here. Another example, also a mid CTO long segment of the RCA, and this is the LAD giving a well seen two of the connections, but with the as in figure A, we cannot clearly demonstrate these channels. Difficulty to demonstrate, but when we invert the grayscale, as you see here in B, it will be more demonstrable, and this is CC2. As you see here, it may be CC2, not CC1. Another example herein, another example of LAD occlusion with the retrograde collaterals from RCA. Also there is a connections, but very faint. We cannot clearly demonstrate it, but when we invert the grayscale with some of modifications, as you see here, a very clear and continuous, a little bit straight connections between the distal RCA and the totally occluded LAD. So to conclude, inverted grayscale cine angiogram with some contrast image modifications, or what's called by ELShafey speculation, could be used in tracking chronic total occlusion, especially when deciding to revascularize using retrograde approach via connection collaterals, as it may help in better visualization of tiny channels. And thank you.